All right, here we are, guys. Welcome to this lecture on understanding pain and pain referral. And this is an extremely pressing problem, especially with respect to odontogenic pain, because often patients come in saying, I have toothache, but we see nothing. Let me help you understand what the concept of pain referral is, what are the characteristics it follows, and more importantly, how do you identify that this is not a dental problem, thereby not excessively treating a tooth. But before I jump into that, friends, quickly, let me give you a brief insight into the history of pain. In the yesteryears, decades and centuries ago, people used to believe that pain was because you are a bad person. Egyptians would say pain is related to evil spirit and religious sin. So if you committed a sin, you would be in pain. And later on in time, Chinese came up with this theory of qi, which means the balance between the yin and the yang, which is the good and the bad. And if you've seen Kung Fu Panda, they talk about qi a lot in their inner peace. All right, moving ahead, friends, this is where Buddhists, so people who follow Buddhism and Gautam Buddha, for the first time ever said pain need not always just be physical in its nature. You could also have an emotional component to pain, and this was massive. Moving forward, it was the Romans who for the first time spoke about a nerval pattern, that is the cranial nerve pattern, that is something that conducts the sensation of pain to the brain. Moving ahead, it was Descartes, as we've all read in our books, who spoke about pain pathways. And the final breakthrough with respect to understanding pain, friends, came in when Melzack and Wall in 1965 published the gate control theory. Now, let me give you a brief insight into these two individuals who came together. When they published their studies, they published two different articles. The first article, which they believed the world will accept, the world did not. But the second article that they did publish, not knowing whether the world will accept it or not, is what the world accepted. And that is the gate control theory. And this came only in the year of 1965. Now, what's important to understand is what is this gate control theory? Because it's something that a lot of people across the globe started taking very seriously once it was published. And it said, when it comes to any form of perceptions, all right, by the brain, there is a priority system. If I may call it, there is a VIP entrance where impulses that come in from different parts of the body actually compete with each other for them to be recognized by the brain. All right. And there are primarily two of these nerve fibers that we talk about and we address here. So there was the A beta fibers. These are fibers that conduct touch, pressure, and motion. Whilst we all have read about the C fibers, which conduct nociception. Nociception essentially means something that is not good. Nociception does not necessarily mean pain. It could be a shock. It could be a thermal issue, or it could be actual physical injury, or even inflammation following injury. So remember, all of that is conducted by the C fibers, whilst you also have the A beta fibers that are going into the central nervous system. Now, according to Melzack and Wall in the year of 1965, all of this happened at the level of the spinal column. All right, that's the dorsal horn of the spinal column. Now, let me give you a quick example of what this gate control was all about. Imagine you get a prick on your finger. All right, so there's nociception that's running from here and you're feeling pain. So what do you do to decrease that pain? You shake your hand vigorously. Think about this. When there is a prick, C fibers are conducting all your nociception to the brain is interpreting that as pain. But the moment you start shaking your hand, the A beta fibers come into the picture, because remember, A beta is to do with motion, right? So A beta fibers essentially gate out the C fibers. So there's like a VIP channel where it says the body believes A fibers are more important than C fibers. So if I can activate A fibers by shaking my hand or by simply rubbing this area, because remember, rubbing is touch, it's pressure, or I put it inside my mouth and close it, creating a vacuum or a pressure seal inside. Essentially, what is the body trying to do? The body is trying to gate out the nociception by activating the A beta fibers, which have a priority or a VIP gate pass in the brain. What happens the moment you stop shaking? The pain comes back, because then the C fibers again become stronger because there are no A beta nerve impulses that are going into the brain. When you get a massage done, why do you feel better when you're getting a massage? Because again, the body is taking or gating away the C fibers that are causing you the lower back pain or the headache or things like that. And the A beta fibers are getting activated. So the world started falling in love with this concept of the gate control. And I remember we were studying about this in our BDS curriculums as well. However, there were certain questions that were not answered by the gate control, which is why, all right, it was 13 years later in 1978 where Wall alone, right, came up with another article, which he said is the gate control theory, but it's re-examined and there is a restatement. The restatement was primarily to do with where the interpretation of the pain was. And earlier they believed the interpretation of pain was at the level of the dorsal horn of the spinal column. But in 1978 is when Wall published to the world that there is a higher center involved. You now have the central nervous system which controls the pain. And how does it control? And we're not talking just pain here, guys. We're talking any and every sensation in the body. It could be a touch sensation. It could be a pressure sensation. It could be a change in the room temperature sensation. It could be wind, or it could be a dry atmosphere. Everything in the human body, externally and internally, is all regulated by the central nervous system. And it is for the first time that they mentioned that there is something called as a descending inhibitory system, which works as a counterbalance to the ascending sensory information that reaches the brain. Now, let me help you understand one very, very simple fact. The brain is active at all times. And why is this? It is so that the human body can maintain balance within itself, can maintain homeostasis, right? Now, what is essentially the function of the descending inhibitory system? And I love talking about this because it is so very fascinating. It is said that the human brain receives more than 100 million impulses every second. More than 100 million impulses every second. Can you imagine the amount of information that is going into the brain? If the brain were to sit and process all this information, it will turn into a catatonic state. It will freeze, brain freeze. But that's not how it works. Why? Because if there is an ascending system which is taking all the information from the body into the brain, there is a gated mechanism. And I love to call or think of this as a filter. The descending inhibitory system is a filter for unnecessary information that is coming from the body. Remember, every cell of the human body is communicating with the brain at all times. Every cell. Every hair follicle on your body is communicating with the brain at all times. This is with respect to motion or changes in its environment. Now, if the brain were to sit and process all of this, we will go completely mad on an immediate basis. But this is where God stepped in and said, you know what? I'm going to create a filter for information that the brain does not need to process until it reaches a threshold. So let me explain this concept to you. Think about it. When I say unnecessary information, I am saying, does the brain need to know which part of the body has blood, how much blood supply? No. Does the brain need to know, let's say, for example, how much air is there in the lung? Doesn't need to know. I or my brain does not need to know how many ml of urine is there in my urinary bladder. I don't need to know until it reaches a threshold. I don't need to know what is the ambient temperature until my skin begins to start either feeling very cold or feeling very hot. That's when the descending inhibitory system goes down and the ascending system goes up. So simple thought is, until threshold is reached, the descending inhibitory system will overpower the basic information that's coming into the brain, not taking it into the brain, but subduing it, saying this is not necessary for the body to know. When I am eating food, where is the food going? My body does not need to know, but I need to know when there is less than adequate amount of food available in the body. So I get a sensation that I am hungry again and I want to eat. So feeling hungry means the descending inhibitory system has gone down and the ascending sensory information now has taken charge and is now reaching the cortex. The cortex essentially is the memory center of the brain, which is where all of these processes take action. That's how beautiful the system is. And as a matter of fact, if you're actually listening to me and trying to concentrate on what I'm saying right now, your descending inhibitory system is working brilliantly because you're able to silence everything around you. You are in the zone. You're trying to concentrate. If someone's called you there, you're distracted. That's your threshold. Okay. Descending inhibitory system gone. Now ascending steps in because something else becomes more important. Sleep. Guys, sleep is the best example of descending inhibitory system becoming stronger because that's the time when you fade the world away. All your senses are at a stop. Your breathing is on, all right, but at the same time, your eyes are shut. So you're temporarily blind. You're temporarily deaf. You don't taste anything. You don't smell anything. Everything is silent. So people who tend to have so people who typically say, I'm a light sleeper, their descending inhibitory system is not very strong. But people who go into sleep and it takes you to cajole them, shake them up to wake them up. These are people who have a very strong descending inhibitory system. Now, why am I talking about this at this point of time? Friends, it is said that people who are in chronic pain, it is their sleep that gets affected. In these individuals, in general, when they are asleep or when they are awake, their descending inhibitory system is at a low, which is why there is excessive information that is reaching the cortex. Unnecessary information is reaching the cortex. This overpowers the human body, right? It makes the human body weaker. And that is what we're talking about. Now, the main crux of all of this discussion is, fortunately, thanks to this gate control mechanism, pain, friends, can be modulated. So there are ways of decreasing the pain interpretation by the brain. You don't decrease the peripheral sensation of pain, but you you accentuate the descending system and decrease the ascending system. Let me give you a few very simple examples of pain modulation mechanisms. The first one is physical, non-painful. You have TENS, you have massage, you have moist heat. Think about how these work. They basically upregulate the descending inhibitory system. They are changing from a C to an A beta fiber. So the moment an A beta fiber gets activated, the C fiber is gated out. TENS, massage, moist heat does the exact same thing on a non-painful level. There are some physical, minimally painful attempts as well, and these involve acupuncture and dry needling. They work on the same philosophy. They break triggers. But at the same time, what they also do is they activate the A beta fibers and gate the C fibers out. That's why you get relief over even a sustained period of time. And the best part, and this is something that I love so much, because we are talking about psychological healing. Remember, the Buddhist said a lot of pain is also emotional pain. Hypnosis works at the higher level. There is no obvious mechanism for hypnosis. Hypnosis says you can put your hand in ice cold water and keep it there, and you will not feel pain if you are in a hypnosed state. Think about it. What is happening? You are gating away all the pain sensation by going onto a higher level, acting at a level which is basically related to serotonin and norepinephrine. Now, I don't want to get into the depths of all of that and bore you, but it's fascinating. If you have this desire to know more, please go and read about these aspects. And the more you read, the more you will love it. And last but not the least is something with respect to us as dentists, right? Don't we know of people who extract teeth even without local anesthesia? So let's quickly look at this video here. Cupping the chin, some cloth on the head, some jerky neck movements, and they believe that you don't need anesthesia. Extraction can be done in a painless manner. All right. Now, let me come to the actual aspect of this presentation, which is pain referral. And let me start off by stating 4 important statements here. All right. Pain referral, friends, is more common than what we believe. Pain referral is the most common reason for treatment failures, the most common reason for failure of treatment. Why? Because remember, success does not essentially depend on the quality of your care. And I'm not saying it does not depend on the quality of your care. I'm saying it does not depend as much on the quality of your care as much as it depends on the diagnosis. And that is why failures are typically because of misdiagnosis. So we'll end up doing root canals for teeth or extracting teeth, and the patient continues to be in pain because the problem was never the tooth. This was pain that was referred to the tooth from a source that was outside. Which is why, friends, I'm going to introduce to you 2 different terms. One is primary pain and the other is heterotopic pain. The difference between these is with respect to 2 very key words, and that is the site and the source of pain. Now, what is the site of pain? The site of pain is where you actually feel the pain. So it's the location of the pain. The patient comes and tells you, I have this toothache, or I have pain in the temporomandibular joint, or this muscle is hurting. So that, according to the patient, that is where they feel the pain. So that's the site of pain. Now, what is the source of pain? The source of pain is the actual origin of the nociception. All right. So let me just give you 3 very simple examples. I'm talking toothache, I am talking TMJ pain, and I am talking temporal headaches. Now, toothache could be a primary problem because there's an actual problem with the tooth and that is causing pain. TMJ pain could be a primary problem because there's a problem either in the joint or in the musculature and there is TMD pain. Temporal headache could actually be a primary problem because there is a issue, typically a neurovascular issue. So there is a primary problem, which means the site and the source are the exact same. If you remember, I mentioned to you in one of my lectures about local muscle soreness, which is a primary pain. And that's what I'm talking about. Primary pain, which means the site and the source are the exact same. But guess what? Toothache could also be heterotopic pain, which means the source is somewhere else. TMJ pain, that is pain felt in the joint. Patient will come and point a finger here saying, I feel pain here. The pain could actually be coming from somewhere else. Fascinating, right? Temporal headaches. And this is myofascial pain. The source is here, the temporalis, the trapezius muscle. But where is the pain felt? The pain is felt here, which is the temporal region. There is a different source, there is a different site, and very, very important to remember, if you want to be successful in your treatment, you will have to target the source of pain. Treating the site with a million different things will not give you the relief that you desire for your patient until you target your treatment to the actual source of the pain. That is how important it is to diagnose where the pain is coming from and then target your treatment to the source and not to the site. Let me quickly also brief you about what heterotopic pain is all about. Now, it's not like all pains are one type in heterotopic group. There are 3 types. You have central pain, you have projected pain, and the one that we will talk about through the rest of this lecture, which is referred pain. What is central pain, however? This is essentially nociception or problems that are present within the central nervous system, but are felt peripherally. So the source is the CNS, but the somatic structures is the actual site of pain. Typically, you see these as brain tumors. You have a tumor in the brain and the effects are seen outside. Migraine issues. Migraine issues is again a neurovascular thing within the brain, but is felt as headaches. So this is a different source and a different site, but the source is central. The next is projected pain. What is projected pain? Where there is essentially impingement or compression of a particular nerve, and then there is pain felt along the entire path that that particular nerve supplies to. And the commonest example in this aspect is sciatica pain. So there is an impingement typically at a lumbar or a sacral level, but the pain is felt way down right side or left side, but is felt way down into the peripheral structures, down the hip, through the thigh into the leg region. All right, so this is projected pain. Remember, projected pain will typically move downwards. So from the nerve compression point downward into the supply area. Another very common aspect to projected pain, and we do have this in our field of work, is trigeminal neuralgia. Remember, the pain is coming from somewhere else. That is the nerve impingement within the trigeminal nerve, but the pain is felt peripherally in the structures along the path. So if there is the ophthalmic branch that gets affected, you will get ophthalmic branch pain, or you may get maxillary pain, or you may get mandibular branch pain. It's very rare to find all three together. All right, but you will typically have one or the other. The one that we're talking maximum about is referred pain. What is referred pain? Pain that is felt in a different nerve from the one that is actually causing the pain. And this can be quite tricky to understand. It is some other nerve that is causing the pain, but it is some other nerve that is conducting the pain. This is massive to understand, because here we're talking about, say, cardiac pain. Someone who has a cardiac arrest, where do they feel pain? They feel pain in the jaw. There is no connection between the nerve that provides any form of sensory or motor supply to the heart as to the jaw. But this is referred pain. And the one that we will talk about in this lecture is non-odontogenic tooth pain. This is all referred pain. Let me start off by helping you understand what causes referred pain. And referred pain, friends, is created by typically what is called as central sensitization. Central sensitization. What is central sensitization? If pain is present over a period of time, which means you have a protracted pain episode, chronic pain, right? There is an alteration in how the brain processes the noxious stimuli, and this results in referred pain. Basically, if pain is present for a long period of time, the brain gets used to processing the pain. Peripheral structures may heal, but there is still pain that is present. And why is it present? Because the brain continues to perceive that pain. The brain hasn't forgotten that the area is healed or the pain has gone. So this is central sensitization, which means the central nervous system has become a player in the perception of pain. So this could be normal somatic structures, but there is an abnormal relay or abnormal interpretation of the nervous tissue. All right. Now, for this, let us first understand what the process of pain perception is. How does the brain perceive something as pain? So let's understand. If you have any source of nociception, this could be injury, physical injury, this could be inflammation, this could be any form of infection, or this could even be some form of pressure, or this could be an electric shock or a thermal change. Anything that is nociception to the body is regarded by the brain as a top priority item, which means nociceptive fibers along that localized area. Here I am giving you an example of masseter. All right. So if the masseter goes into a local muscle soreness, excessive use or trauma, all right, and what happens in this region is the nerve that supplies this creates afferent or sensory impulses along three different chain of neurons. So the first neuron that you see here in red is called as the first order neuron. And this is typically for our field of work, one of the cranial nerves. What we are dealing with is, in this case, the mandibular branch of the trigeminal nerve. Okay, this goes and takes the impulses via the Gazarian ganglion, which is your trigeminal ganglion, into the spinal tract nucleus. So what you see here is the spinal tract nucleus where the first order neuron goes into. Now it is here that the first order neuron, all right, releases its impulse, and there is an electric current that jumps and accentuates a second order neuron. The second order neuron goes from one spinothalamic tract into another onto the opposite side, and this is your ascending pathway. Where does the second order neuron go? It goes into the thalamus. The thalamus, or the thalamus, friends, is the relay center of the brain. It's in my opinion the best thing that happens to the brain, because it is from here that a decision is made whether this is important for interpretation or is it not? If the thalamus believes the brain does not need to know what this sensation is, it accentuates the descending inhibitory system and the body does not realize. So the entire nerve impulse goes dead right there. The brain does not freeze because of the excessive amount of information that's coming to it. But if the thalamus believes that this is nociception, it is bad, this is going to create damage to the body, it immediately activates a third order neuron. And this third order neuron goes to a specific area of the brain cortex. And it is here that it is interpreted as pain. The moment the cortex interprets it as pain, we will feel the sensation of pain. And this happens at crazy speed. So it's almost instantaneous. You touch something hot and whoa. Okay. Through this milli micro fraction of a second, what has happened is you have had nociception that has been activated in the first order, second order, and the third order neuron and interpret as pain. Now, the beautiful part in all of this, let me zoom into this to help you understand. Nociception starts where there is the actual tissue injury or the source of nociception. Look here, from here you have the first order neuron. Remember, at the first order neuron, it is not pain, it is nociception. Because nociception could be pain, it could be pressure, it could be shock, it could be electric, it could be anything, it could be thermal. All right. So it is nociception at the first order neuron. If you can see, this first order neuron has gone through, this is a diagrammatic representation of the Gazzarian ganglion. So this is the mandibular branch of the Gazzarian ganglion. This will be the maxillary. This will be the ophthalmic. So from here it goes, this is the spinothalamic tract. Okay. This is the dorsal root or the dorsal horn of the spinothalamic tract. From here, it is the second order neuron that gets activated because of the nerve conduction. And this is where I spoke about the ascending pathway, and it goes into the thalamus. And from the thalamus, it is from the thalamus that it goes into a specific area of the brain via the third order neurons where it is interpreted as pain. Now, please try and understand. First order neuron, second order neuron, third order neuron. Through all of this pathway, it is nociception. It is only and only at the cortex. It is only and only at the cortex where the body realizes whether this nociception is pain, whether it is electric current, whether it is thermal change, or whether it is some form of infection, or whether there is actual physical injury. Amazing, right? It is the cortex. Remember, the thalamus is the relay center. The cortex is the memory bank. It is the cortex that interprets the pain. Which is why when you say hypnosis works, hypnosis is working at the level of the third order neuron. It is the higher centers. Emotional stress works at this level, which is why peripherally there is no problem, but centrally there is excitation. And we're talking about prolonged emotional stress without the possibility of an escape. At least that's what the individual starts thinking. Now, very important. How does the brain know in which part of the body is the actual nociception coming from? And this is fascinating because the cortex, friends, as I zoom into this beautiful picture, is designed on the basis of the homunculus man. And let me show you a picture of the homunculus man. Massive face, massive hands, very small torso. And if you look at this diagram that I've charted out here, this is the area which is for the face. This is for the teeth. This is for the tongue, which is why when I was talking about the masseter muscle, I was showing impulses coming into this region because this area of the cortex is designed to understand pain that is coming from the face. Now, if the pain were coming from, say, the soul, those nerve impulses by the hypothalamus would come here because this area of the cortex is designed to interpret pain from the feet. Isn't this absolutely fascinating? Why do we always are so conscious about this area? We have maximum tactile feeling and sensation in this area. Why? Because the body has given maximum sensory neurons to this. Look at the size of the hands of those homunculus men. It's massive. That is a sensory homunculus man, by the way, the one that you see on the left. Big face. So the face is a large area of sensory input that is occupied in the cortex per se. And I believe this is fascinating. And there is a separate area in the brain for interpretation of tooth pain, a separate area for tongue pain. But look how close they are to each other. So if there were pain sensation in the tooth, it will come here. But if there's a pain sensation in the lip, it will go into a slightly side portion of the cerebral cortex. Now, isn't this absolutely stunning a way of working? I mean, no human, no computer can match what the brain does. But remember, because the system is so very complex, things can go wrong. And I think of what can go wrong as a cross connection. It may not be very common today, but if you've ever had the privilege of using one of those dial-up phones, वो पहले कई बार होता था ना यार, क्रॉस कनेक्शन हो जाता था, कौन बात कर रहा है किसी के साथ कुछ रियलाइज नहीं होता था. Why? Because the system inside is so complex. There are cross firings that can happen at some times, and the human brain is beautifully complex an organ. All right, so there can be cross connection that can happen at the CNS level, and this is what causes referred pain. But remember, when the brain perceives referred pain, it can cause changes or issues at 3 levels. One is the sensory afferent neuron level, where you get sensory or nociceptive pain. It could be at the motor or the efferent neuron, where the muscle gets, let's say the muscle goes into a state of co-contraction, and that is why there is pain in the muscle. Or it could be some form of an autonomic response. So let's look at all of these 3 individually. First, let me talk about sensory or afferent neurons. Here I have put 3 different nerves. Ophthalmic nerve, you have the auriculotemporal nerve, which is the primary nerve that supplies the temporomandibular joint, and an accessory nerve that supplies the trapezius muscle, because often referred pain is between these areas. So I'm going to highlight these 3 specifically. Now, this is the area that I have highlighted on screen, all right, where central sensitization typically occurs. And why is this? Because the peripheral nerves have 2 features that are part of its anatomy or diagrammatic breakdown. There is divergence and there is convergence. What is divergence? Divergence essentially is peripheral neurons that split into multiple interneurons. All right. So if I were to show this to you, the red gets split here, the blue gets split here. As you can see, a primary peripheral nerve gets split into multiple interneurons. What is convergence? Convergence is multiple peripheral neurons meeting into one central neuron. As you can see this here, there are multiple interneurons that are meeting into one central neuron, and this central neuron then conducts the this is the second order neuron basically. So the first order neuron is where the divergence is, and then convergence happens at the level of the first and the second order neuron, and then it goes as the ascending pathway. Okay, let me give you a simple scenario, and this is a common scenario that you will come across if you start treating TMD pain. If you have a patient who's just been in an accident, a road traffic accident, okay, remember when there is a road traffic accident, there is a whiplash injury. So there is a hyperextension injury, and this individual tends to then have pain in the neck because of the sudden cervical movement that has occurred with a stiff neck. There could be trigger points that are present in that region. So let me explain to you this aspect of the source of an acute pain, which is present in the shoulder. That is why you see the red nerve, which is the accessory nerve, which is showing that bulging feeling, that this is where the source of acute pain is. So look closely. Nociception from the shoulder will be felt by the cortex as pain via continuous neural activation that goes through. This is primary pain. Now this pain is good. It causes a stiff neck. Why is it good? So that you know you don't have to move the neck too much, because if you do that, you will stand up hurting yourself more. So this is a form of good pain because it's a reminder for you to not abuse the tissue. But very, very important to understand, literature says more than 1/3 the patients who have whiplash injury suffer from prolonged neck pain, even 1 year after the actual injury. Now, remember, when I say nociceptive pain is good, it is only as long as it is acute. Chronic pain has no good role to play. Chronic pain is bad. End of discussion. Acute pain is typically good. Chronic pain is bad. So what happens now? If this patient has pain for 1 year, that becomes a source of deep pain input. And please recollect my lecture on etiology 5. The fourth etiology that I mentioned was deep pain input, cervical pain. So this becomes a source of deep pain. Now, I want all of you all to kind of highlight and concentrate on this part of the screen, which is where central sensitization essentially occurs. Look at primarily at this point, the red neuron at the divergence level. Currently, the entire nerve conduction is happening only and only along the accessory nerve. But the accessory nerve within the spinothalamic tract area has a divergence. So there is a high possibility that now there could be a divergence or a cross connection that happens in that nerve. So a divergent nerve, which is not the actual area that supplies that nerve, that supplies the tissue, gets activated. Now what happens? Because that neuron or that interneuron has convergence with a central neuron, you could land up getting pain along the blue line, which is the blue nerve. Which is the blue nerve, guys? The blue nerve is your auriculotemporal nerve. You know what happens? This patient starts feeling there is pain present here, referred pain. Where is the actual source of pain? It is here. But because there is chronic pain, because it's protracted pain, central sensitization steps in, cross connections happen between the interneurons, and you may land up getting pain elsewhere in the body. That is a site of pain. There is a different source of pain. But remember, to the cortex, this is two different pain pathways. So the cortex will tell the patient, you have pain here and you have pain here as well. This is very, very important to understand. The TMJ area that the patient is believing the pain is only the site of pain. It is not the source of pain. There is one source of pain, but there are two sites of pain in this patient. Now imagine this patient after the accident went to an orthopedic. So what did the orthopedic do? The orthopedic told the patient, you know what, you could probably just put a neck brace here and avoid movement. But if the pain continues over a period of time, this patient may start getting pain in the joint. So this patient goes back to the orthopedic and tells the orthopedic, you know what, I'm now beginning to get pain in this region. The orthopedic is like, you know what, this is TMJ pain. Let me refer you to a dentist. Patient comes to you. Patient says, I have pain here. Patient will probably never tell you I have pain here. Why? Because the patient believes you are a dentist. Why will you want to know about this pain? Patient will be like, I have pain here. What will you do? You will think to yourself, this is TMJ pain. And you may land up now treating this patient with a splint. Guys, think about it. You are only targeting the site of pain. You are not treating the source of pain, which means your splint won't work. There will be no change in the patient's symptoms whatsoever. Unfortunately, clinicians and researchers alike draw conclusions saying splints don't work. My friend, it is not the quality of your treatment that matters, but the actual diagnosis that matters. If this was a TMJ issue, be rest for sure your splint will work. But this is not a TM joint issue whatsoever. This is merely a site of pain. It's not the source of pain. So please understand how important diagnosing is. And referred pain can be very, very tricky to diagnose. You have to go and dive into the depths of the history, and that is when your patient will tell you that, yes, I have a stiff neck. Oh my God, you should have told this to me before. I didn't have to do all of this. All I need to do is send you to my physiotherapist. My physiotherapist will take care of the neck. And guess what? When you treat the source, the site also heals. Because if the nerve conduction from the source is taken care of, there is no central excitation anymore, which means your pain, not just at the source, but also at the site, will go down. That, my friends, is referred pain. I was talking about sensory. Let me quickly talk about motor here. Now, when I speak about motor, again, I'm talking about the same auriculotemporal. All right. Sorry, the accessory nerve. From the accessory nerve, you may have one mechanism that I spoke about that takes it along the convergence up into the ascending system. But when there is CNS activity and central sensitization, you also get antidromic, or you have neurogenic inflammation, which means the entire pain pathway reverses. Instead of pain going up, the pain from the brain goes actually into the muscle. So I want you to now trace the blue one, which is the mandibular nerve, but not the one that is going into the CNS, but actually into the periphery. As you can see here, cervical pain actually causes muscles in the masseter to contract. Imagine you have pain here, but if the pain continues for a longer period of time, you need not only have sensory side pain, but you may have actual co-contraction that happens in the masseter muscle. Crazy. This could move even further. Look at the yellow neuron, which is going and supplying the temporalis muscle. This muscle could also start firing. You could have someone says, I'm getting tension pain because of a trigger point that is present here. This is your myofascial pain. Myofascial pain says when you have a trigger that is present here, I'm not just talking about sensory, but I am also talking about a motor neuron getting activated. So there is actual co-contraction that is present in the peripheral structures. Remember, motor is all to do with muscle. So we're talking about muscle co-contraction. Initially, it's protective in nature. Later, it becomes local muscle soreness. That's simple, right? This is pain during function. This could be a true TMD secondary to a cervical. So this is a patient who you may have to treat this. You may have to treat this. Why? Because these have actually become TMD problems. But this is secondary TMD, and there is a primary etiology which is present here. And how do I come to know whether this is secondary and this is primary? This is a classic situation where the patient says, I'm having pain here and I'm having pain here. Oh, fantastic. I know this is a TMJD, or this could be an occlusal muscle disorder. I'm giving the patient a splint. Patient wears the splint, and for the next few days, patient says, wow, I'm feeling so good, doc. Thank you so much. But guess what? Typically 1 or 2 weeks later, the patient comes back saying, doc, that pain is back. No problem. Let me adjust the splint a little more. I adjust the splint a little more. The patient goes out saying, yes, I'm feeling good. Few days later, the patient comes back again. You adjust, the patient feels better, goes out again. A few days later, comes back. Why? Each time you adjust, the patient feels better only for a short period of time. The answer is this is secondary TMD. There is some other source of TMD which is primary in nature. Typically, this is referred pain from the cervical region. So please send your patients to the physiotherapists. They are best trained at releasing deep tissue massage. Release those tissues. Release the spasm or the nociception that is present in the primary site. The primary source, and you will feel a relief that is sustained within these muscles as well. That's where I keep telling you, my physiotherapists make me look good. It's a huge part of your team work, which is why in the teamwork presentation, I had put physiotherapists as the first doctor as a part of your professional team. I hope this is all now making sense. You have one single area that is the primary source of pain that now causes a secondary source of pain, and you have pain that is referred into different areas. Look here, I'm giving you very, very simple but very, very important areas of where referred pain is. Now, the best part is that with referred pain does not happen just abruptly and arbitrarily anywhere. It does follow rules. 90% of referred pains will follow rules. So if you have a muscle or a tender spot that is present in this region of the head, it will refer pain into a specific area, and that specific area is the occiput. So if someone's saying I'm getting pain here, there's a possibility that there's a trigger point that is present in the occipitalis muscle in this region. All right. Moving this further back into the base of the HEC, where you have the superior nuchal line. And if there is a source spot or a pressure point or a trigger spot that is present in the base of this occipitofrontalis muscle, guess where will it refer pain into? It will refer pain into the head or the top of the head. This is the scalp. Also, if your patient says, I have pain behind the eye, something's bulging or pushing out, guess what? Look for the source of pain at the back of the head. You take away the trigger and the rest of it also goes away. If this is further down, if this is into the suboccipital muscles, you will classically get sinus headaches. So sinus headaches may have nothing to do with sinusitis. This may actually be a trigger point that is present at the back. This is again where cervical traction, cervical release and physiotherapy is massive. It can take care of these chronic sinus headaches. Very, very important area, guys. Very important area, this. Why? Because this area will refer pain directly into your temporomandibular joint. This is your splenius capitis muscle. And I have shown you how to palpate this muscle in the diagnosis section. So please send your patient to a physiotherapist and tell them this patient has TMJ pain. This might be referred pain from the splenius capitis. Please release the capitis, and they will do that for you. If the pain goes, well done, my friend. You are spot on with your diagnosis. You did not have to treat the teeth or the splint or do any other thing for this patient. Last but not the least, I am talking about a trigger in the trapezius, and this is typically in the upper part of the traps itself. And this will refer pain into two very important areas. I've already spoken about temporal headaches, which I have suffered from, which were managed by doing dry needling in these trigger points. But also patients who say, I have pain at the angle of the mandible, and you don't see anything there. This could very well be referred pain. Please send your patient to a physiotherapist. Tell them this could be trapezius referred pain. Please take care of the traps. The angle pain may completely go away. That's the power of correct diagnosis, friends. Last, I come to the autonomic neurons, and I know I'm exceeding this lecture a little bit. I believe it's very, very important for each and every one of you. Now, remember, although you have a sensory chain that is going up, there is also an autonomic chain which is taking the sensation, not the sensation, but the neural information from the brain coming down the spinal tract outside into the peripheral structures via a group of ganglion together, which is your sympathetic chain. And remember, the sympathetic chain then takes care of all the uncontrolled aspects of the human body, the involuntary things. When the sympathetic activity or the sympathetic chain gets activated, friends, typically your patient will tell you things that make no sense whatsoever. Patient says, when I have pain this side, my eye becomes red. Only one eye becomes red. Sometimes my eye starts tearing. I'm not crying, but my eye starts tearing. I see water running down the eyes. Some say I feel dry. Some say I have mucus secretion coming only from one nostril. That's the diagnostic aspect. Remember, if you have cold or rhinitis, typically it's bilateral. You don't have one side rhinitis. You don't have cold only on the right side of the body. But when the autonomic nervous system is activated, it often is unilateral. Some patients will tell you, when I have pain, I feel this area is swollen, but there is no physical swelling that is present there. Remember, pain or nociception will not cause swelling, inflammation will. Okay, pain will not. So remember, these are autonomic responses to chronic pain. Try to identify the source, because if you're able to, all this will completely go away and you don't need medication whatsoever. Now, let me quickly highlight to you two very important characteristics of referred pain. First, referred pain usually occurs along different divisions of the same nerve that mediates the pain. We have worked with two branches of one nerve all our life: maxillary branch, mandibular branch of the trigeminal nerve. Okay, so remember, the trigeminal nerve essentially conducts referred pain in a vertically laminated pattern. I'll help you understand what that is in just a bit. But what is very important to remember is trigeminal pain will never cross the midline. If the right side is affected, only the right side is affected. If the left is, only the left. It will not be like right mein problem hai, so you will feel it on the left side. That will never happen in the trigeminal nerve. Now, what is this vertically laminated pattern? The face is divided into these laminas that are in vertical orientation. As you can see, I am drawing these 5 different laminas. Now, pain referral happens within a lamina alone. And this lamina is basically designed on the basis of how the spinothalamic tract nucleus essentially is. Okay, so it also has these 5 chambers to it, which means if there is a neural stimulation that happens in the yellow zone of the face, it will go and conduct, or the first order neuron will meet the second order neuron with its convergence only in the yellow part of the spinothalamic tract nucleus. It is not that simple, but I've just created this so that you can understand and correlate why this vertically laminated pattern per se exists. So let me show you a situation where the patient has a mandibular molar that is the source of the problem, but the patient is feeling that the pain is radiating to the upper molar. Patient बोलता है ना ऊपर के दांत में भी दर्द हो रहा है, and you look and you say problem नहीं है, referred pain है. हम इतनी आसानी से बोल देते हैं. Let me bring more picturesque understanding to what actually is happening for us to say this is referred pain. At this point of time, let me start off by telling you the source of the pain is a mandibular molar. So this is a mandibular branch issue, but it will radiate to a maxillary branch along the vertical laminated pattern. So as you can see, a mandibular first molar will radiate only to a maxillary first molar of the same side. It will not radiate to a maxillary central. I hope you're understanding the vertically laminated pattern now. Now here you can see that the mandibular nerve has been activated. But when the mandibular nerve has been activated, there is always a possibility that there could be a cross connection at the spinothalamic tract nucleus region. And that is why now the blue neuron also gets fired. When the blue neuron gets fired, remember, this is perceived by the cortex as pain from the first molar. Although it is not true pain, this is a site of pain. So the source of pain is the mandibular molar, but because of central sensitization and because of a cross connection, the individual feels pain along a vertical laminated pattern in another branch of the same nerve. That's key. Another branch of the same nerve. And we are talking about the maxillary and the mandibular branch of the trigeminal nerve. This is the first. Now I'm talking about a second clinical characteristic. And I love this characteristic. Why? Because there is no compulsion कि वो उसी nerve के अंदर होगा. If another nerve gets affected, which means there could be a cross connection between the accessory nerve and the trigeminal nerve, or it could be an abducens nerve and another nerve. So if there is a cross connection, it will follow a cephalad course to the nerve that mediates the pain. Now, what is cephalad? Cephalad means moving upwards in the body. Caudal means moving downwards in the body. So let me give you a very simple understanding of this cephalad aspect. Typically, if someone has pain in the spinal region, sacral problem, okay, so pain in the sacral region will typically be felt by an individual as pain in the lumbar region. That's how things work. Referred pain is not in the same area. Referred pain is always a different site from the source. So the source is the sacral vertebrae. So nerve compression in the sacral vertebrae. This could be felt in the lumbar region if it's referred. If it's going downward and you're talking about a sciatica pain, remember that is projected pain. That is not referred pain. Referred pain is always upward. So sacral pain is felt in the lumbar region. Lumbar pain is felt in the thoracic region. Thoracic pain is felt in the cervical region. Any guesses where cervical pain is felt? Isn't it astounding, guys? Cervical pain is typically felt in the face. That is why if you have trapezius pain, you will get a site of pain, which is the face. The source is here, the site is here. Will ever pain in the face radiate or referred pain to the shoulder? Never. Never. Because remember, referred pain always follows a cephalad course upwards. It never follows a caudal downward. Isn't this amazing? Cervical pain felt in the head region. And very, very important is clinically, how do I differentiate? मैं समझ गया कि ये site है and source है, but मैं कैसे find out करूँ clinically? And I'm going to give you 2 simple tips to do. And they're very, very simple, guys. Very simple. And if you follow them, I'm telling you 19 out of 100 cases, you will be right with source and site. First, Local provocation of the source always increases pain. Local provocation of the site does not alter the pain. Simple example. If you run a marathon and you have calf pain, what will happen when you press the calf further, or what will happen when you load the calf further? Excessive loading or provocation of the muscle will cause more pain. But if you have calf pain, which is a site of pain, imagine your calf pain is because of sciatica. The problem is somewhere else. When you press the calf, you will not feel any pain. When you go jogging, you will not feel any pain because the calf is a mere site of pain. So remember, local provocation of the source increases pain. So if someone has TMJ pain and you provocate that area, you palpate that area, the pain will increase. That is the source. If you have temporal pain and when you press that temporal pain and you feel better, you are doing gate control. If you have headache and pressing that area of the head makes you feel better, guess what? That is probably only the site of pain. It is not the source of pain. Because if this was the source, when you press, the pain should increase. That's how strong this statement is, friends. Okay. You have to do three things if you want to differentiate whether the patient's pain because of a TMD is true source or site. First, ask them, when did you last eat a burger or a pani puri? The basic thought is, let's understand, is the patient able to open as wide as is needed to eat something like that? Because if they can easily open that wide, this is not the source of the pain. It is probably the site of their pain. Okay. Wide opening without any troubles means it's the site, it's not the source. Make the patient clench the teeth, move forward, move right, move left, open wide, and ask the patient, when you do all of these movements, does it hurt you more? Clenching, does it accentuate your pain? Because if this is the source of pain, clenching will always cause more pain. It will never not change. If it does not change, if the patient says, no, I'm clenching, but I don't feel any change, this is only a site. The source is somewhere else. I hope it's making sense. Last but not the least, actually go ahead and palpate the area. If the patient says, I'm getting pain here, physically palpate that area. And I've shown you already how to palpate the masseter muscle. So keep walking the muscle, basically. Walk it over the entire muscle. If there is any tenderness that the patient feels or the discomfort increases, that is the true source. It is not a site. But if there is no change, it is the site. And please don't check for pain and by asking the patient, does it hurt? Please don't ask the patient, does it hurt? Ask the patient, does it hurt more? They are already in pain. So when you palpate or when you ask them to open wide or when you ask them to clench down, is the pain more? If yes, that's the site. It's the source. If no, it's the site. All right. So simple example here. When I am palpating the TM joint area, when the source is a cervical issue, there will be absolutely no nerve conduction that will happen from that area. Nociception, there will be no nociceptive response from this region. So the brain will not think of this as pain because this is regular palpation. But when I palpate the true source of pain, look at the lal batti in the cortex. It's activated. And guess what? When you press on this region and keep it pressed at the source, you will not only feel pain at the source, but you will also feel pain at the referred site. I hope this is making sense. Provocation of the source increases the pain at the source and at the site. Provocation of the site does not alter the pain sensation at all. So upon palpation, upon clenching or upon wide opening, if the pain goes up, you are at the source. If it does not go up, you are only looking at a site or the manifestation of pain. That is not the true origin of pain. It is only where the patient perceives the location of pain. I hope that is clear. Okay, this is the headache aspect that I already spoke about. When you press here and if you feel better, it is the site of pain. It's not the source of pain. The second very important clinical differentiation, and I personally love this a lot because there's no question mark to this at all. There's no subjective variation to this aspect at all. And this is to do with the help of local anesthesia. Numbing the source eliminates the pain. Numbing the site does not alter the pain. So let's bring out our 2% lignocaine. All right, now let's understand upper molar, lower molar. If the source is the lower molar and I give an infiltration into the upper molar, there will be no change in the pain perception because that's not the true source. The area will go numb. The patient will say, I feel numb, but the pain is still there. And if you want to differentiate whether this is pain coming from the upper molar or from the coming from the lower molar, please, local anesthesia is your key. But remember, the moment you now anesthetize the mandibular molar, which is the true source of pain, guess what will happen? The lal batti that is happening on the cortex, both of them will go away because the nerve conduction has been broken down by the local anesthesia. Where will the pain go? At the source, which is the mandibular molar, as well as the site, which is the maxillary molar. That is how strong use of local anesthesia is. So remember, if the patient's pain goes down with the help of local anesthesia, you are at the source of pain, you are not at the site of pain. And I cannot overemphasize how important this is with respect to clinical dentistry, so that we don't land up misdiagnosing and incorrectly treating a tooth. Worst case scenario, extracting teeth. Trigeminal neuralgia, often people end up getting teeth extracted because they believe that's the source. No, it is only the site. And if you have referred pain that is coming into the tooth, you have to numb the source. Okay, so this is the clinical scenario that I have already discussed with you. Pain in a maxillary molar, tooth looks good clinically. Pain on percussion is negative. Radiographically, there's no problem. Thermal test is normal. You prescribe analgesics, patient comes back still in pain. You prescribe antibiotics, patient is still in pain. You land up doing a root canal, there is still pain. You do a root canal for the adjacent tooth, there is still pain. You put it through a CBCT, there is no missed canal. The obturation is fine. You now land up extracting the tooth, there is still pain. The patient continues to come back to you telling you, I now feel pain in the extraction socket. You are now troubled. The only thing you're looking for is a release, and you look to refer the patient. It's already too late, my friend. You should have thought of this earlier. I now come to the last leg of my presentation, which is the most important, which is non-odontogenic tooth pain. There are different sources that can refer pain into the tooth. Remember that. And there are multiple sources. It could be muscular, it could be vascular, it could be neural, sinus, or cardiac. I am here to talk to you about 3 primary muscles that do often refer pain into the tooth, but with very, very peculiar and specific distribution. And I'm going to help you understand that. 3 muscles: temporalis, masseter, and the anterior digastric. If you have non-odontogenic pain, you can't see an obvious source of pain. And if the patient says, I am feeling pain in the tooth, please send the patient to a physiotherapist telling them, I believe this pain is either coming from the masseter, the temporalis, or the anterior digastric. Please work on these muscles. This may take away the patient's pain for good. All right. Now, remember, there is a peculiar distribution pattern. So when I'm talking about the temporalis, if you have a source that is present either in the tendinous region of the temporalis or in the anterior belly of the temporalis. So basically in this region, if there is your trigger point present, this will radiate pain to the maxillary central incisors. Imagine, this is the source. Patient is feeling pain in the maxillary central. You look at the tooth, it's absolutely fine. Central incisor, lateral incisor. देख के कुछ नहीं दिख रहा लेकिन बोल रहा है पेशेंट इधर पेन है. This could be a trigger that is coming from the anterior belly of the temporalis. Sinus ache. If patient says I'm feeling pain in this region, it could be a trigger here. If the patient is complaining typically of a band of pain in the anterior temporalis muscle, and this is very common, this is very, very, very common, anterior belly of the temporalis muscle, the trigger is actually in the temporal muscle itself. Break the trigger and the toothache or the headache or the sinus ache will go. What if this trigger is present in the middle belly of the temporalis? This will refer pain into the maxillary premolars. Imagine maxillary premolar patient saying, this tooth is hurting, you tap, there's nothing, thermal sensation, nothing, tactile sensation, nothing, X-ray shows nothing. Patient says, yes, it is this tooth that is hurting. Please, on that same side, the middle belly of the temporalis could have a trigger point. What if the trigger point was in a posterior belly of the temporalis? This will refer to the maxillary molars on that side. How often do we have a patient with a maxillary molar that is painful and you cannot see any obvious sign of breakdown? Nothing that tells you this is a odontogenic problem. And we're very good at ruling out that this is an odontogenic or a non-odontogenic problem. All is that we didn't know where is the actual source coming from. Please refer this patient to a physiotherapist and tell them, I believe this is coming from the posterior belly of the temporalis. Please release that. We are not trained to do that. We don't have to do that. Refer them out. That's the best thing. If you care for the patient, send them to a competent authority. Don't try to do this yourself. All right. I hope you understand this. Now, the most important thing in this, remember, temporalis muscle will only cause referred pain to maxillary teeth. So if it's a mandibular tooth that is hurting, it is not from the temporalis muscle for sure. Do you realize how powerful this is from a clinical diagnosis standpoint? You no longer have to do unnecessary root canals. And I'm sure you all are cringing thinking about this 1, 2 or multiple patients that you've treated, not knowing मैं इसके लिए क्या करूं. You kept treating them because you were thinking what you are doing will help them. But remember, you were only treating the site, you were not treating the source. What if this was a mandibular molar that was hurting? This could be from the masseter muscle, and masseter muscle can have plenty of trigger points. And I'm telling you this for a fact. Okay, if it's if it's in this region, essentially this goes to a maxillary posterior. So remember, maxillary posterior could be temporalis or it could be masseter. But if it's a mandibular molar, it is almost always from the masseter region. If it's the lower incisors, it's from the anterior digastric. See how beautiful this pattern of distribution is? Temporalis, maxillary. If you have your masseters that are providing or creating the source of pain. Now, the beautiful part about the masseter is masseters will only and only cause pain that is in the posterior region. That is the maxillary or the mandibular posterior teeth, or the deep masseter can also cause ear pain or TMJ pain. If you have referred pain in the ear, this could be a trigger that is present in the masseter muscle, the deep belly of the masseter muscle. Once again, remember, a masseter muscle will only and only refer pain to posteriors, maxillary and mandibular posteriors, never anteriors. If it's lower anteriors that are sensitive or hurting, this could be the anterior digastric muscle, as I just mentioned to you. Now, as I close my presentation, I'm going to give you 2 very important slides, life-changing slides. Please try to brainstorm this into your head. Remember, not all pain felt in the temporomandibular joint is TMD pain. It could be referred pain from a different source. Also on same lines, not all pain felt in the teeth is dental pain. This could be non-odontogenic pain. Pain felt in the teeth coming from somewhere else. Remember, your patient's chief complaint does not always necessarily have to be the source of pain. Your patient will always point to the site of pain because that's where they feel the pain. It is up to us as astute clinicians to be smart enough to identify the source. So first think, then treat. When you're talking about referred pain, friends, we have to start thinking like the Sherlock Holmes. With that, friends, I come to the end of my presentation on understanding pain and pain referral. I hope this time that I've spent with you adds value to what we can do in terms of potentially helping a patient identify the true source, but more importantly, not doing incorrect dentistry because we were blinded by what the patient was telling us and we directed our treatment at the site. Look for the source, because 1 million treatments only and only targeted at the site will have no relief until you finally identify the source and extend treatment there. That's when the pain will not only go from the source, but also from the site. I wish you guys the very best with pain management in your practices. Take care. Bye-bye.